Okay, good day to everyone and welcome to Criticare 2021. My name is Dr. Sanjit and I work in a hospital by the name of SL Raheja, Fortis Hospital. I manage the Department of Critical Care over there. And I'm invited here to talk about combating MRSA, exploring new options. Well, is that even a problem? Let me start this entire talk by asking whether that's even a problem. Well, there are a large number of ICUs in Bombay that would say, no, I don't have an MRSA problem. There are a large number of ICUs that would talk about saying that they haven't seen MRSA and they really don't have a problem with MRSA or for that matter, gram-positive organisms. Well, we conducted a study in among all our patients of diabetic foot that actually came into our hospital for a period of around 1 year. And what we found was that the incidence of having one bacterial species was 44.3%, and the predominant bacterial species that we got was Staphylococcus aureus, 26.9%, and in fact, a very large number, almost 80% of them were actually MRSA. Well, this is another study that we recently reported in literature where actually looked at gram-positive organisms from the year 2015, 2016, and 2017. And if you look at it, the prevalence of Staph aureus was anywhere at 48.8%. I mean, 361 cases on 2015, 338 on 2016, and 342 in 2017. And when we looked at the predominant source of infection, it looked like it came almost 61% came from skin and soft tissue infections, whereas we also got it from respiratory tract as well as from the bloodstream. And when we looked at this microbiological profile of this same organisms, what we found was that there was almost a 30% prevalence of MRSA and a 67% prevalence of MSSA. And this was almost the same in 2015, 2016, and 2017. And it's not very different in 2019 or 2020 as of now, is what I believe. So this means to say that yes, it does look like my ICU and my hospital does have an increased prevalence of gram-positive organisms, and one of the main organisms that we are having is MRSA by the looks of it. Well, even other studies have actually said the same thing. This is a recent study that came out from the group of Balaji Veeraraghavan and Sunanda Rajkumar, which actually said the prevalence to be anywhere from 15 to 45% with an overall prevalence of 37.3%. So this means, yes, we have a problem, and yes, it can be in various tissues. Let it be the skin and soft tissue, the lung, the bloodstream. It needs a great drug to reach, kill, and eradicate, and that too very, very safely. And that's where I put the entrance of the new standard of care for management of MRSA infection, which I believe would be levonidifloxacin, a great drug which has given me great results as of now. Well, let's think about this particular drug. This is one of the few drugs that have attained the status of qualified infectious disease product based on coverage of 6 CDC identified threat pathogens. That's a special status that the US FDA gives, and it's given a fast track review to accelerate the drug development cycle. So let's think about this drug. 18 clinical trials, phase 1, phase 2, phase 3, more than 50 international publications and posters that have gone ahead with this particular drug, and 1,381 Indian subjects that have been subjected to this drug in phase 1, phase 2, and phase 3. This means there's a great body and a level of evidence with respect to this particular drug by the name of levonidifloxacin. Well, let's look at the structure of this drug. The structure of this drug is extremely different from a usual quinolone. In fact, even the oral and the IV levonidifloxacin, they've got a very different and a very unique absorption pathway that they have with an, and the oral drug has got almost a 90% bioavailability with an extremely good tolerance potential is what it looks like. And importantly about this particular molecule is that it gets enhanced permeation, enhanced target affinity, and because of its unique structure, it has an enhanced activity even in the acidic environment. In fact, one of the very unique properties that I found was that it has potent activity against sequentially selected mutants and has a very narrow spectrum and a narrow mutant selection window against quinoline resistant Staphylococcus aureus because it preferentially targets DNA gyrase. Well, that's a very unique property of this particular anti-MRSA drug, lemonadifloxacin. And if you look at the entire spectrum, it covers MRSA, VRSA, Visa, linezolid, that is not sensitive to the rest of the Staphylococcus aureus, macrolide and penicillin, the Streptococcus pneumonia resistant penicillins, Enterococcus fecalis. It also looks at some gram-negative pathogens like Moraxella catarrhalis, H. influenza, quinolone, a large number of atypicals like Mycoplasma, Chlamydia, Legionella, and also it covers the anaerobic spectrum, which includes Clostridium and Streptococcus species. What is also very beautiful, and I think that's very unique about this drug among the gram-positive drugs that we have, is that it's got an extremely good in vitro bactericidal activity against methicillin and quinolone resistant Staphylococcus aureus in biofilms. Now, this is something very important in intensive care, because in intensive care we got lines, we got catheters, we got tubes, and definitely that is where they colonize and that is where they permeate, and from that it is from there that they actually metastasize to different places and cause the various problems that we face with gram-positive infections. And the unique property of this particular drug is that it is extremely active against the biofilm, and it has got a bactericidal activity. Well, another important part of this is that it lowers the MICs extremely well. I mean, that's what it looks like. It's got a beneficial feature in rendering clinical efficacy in infections such as skin and soft tissue infections, diabetic foot infection, and respiratory tract infections. And this potent intracellular activity that it has will definitely help to work in the acidic medium, which thus enhances the activity of this particular molecule. And that's what the driver is. That's the driver behind the potent MRSA killing under intracellular conditions that it basically has. Well, another very important thing that it also has is it has got some kind of effect against cytokines. I mean, it does drop the interleukin 6 levels. In fact, if you look at the red bars that is there on your screen, that is lemonadifloxacin treated. Whereas if you look at the linezolid, it is the blue bars clearly indicating that the IL-6 levels and the TNF alpha levels seems to be kind of going lower when you're actually using lemonadifloxacin, and probably that's the reason that in my hospital when it has proven a great benefit in patients who are going through COVID as of now. Also, what we know about this drug is it's got excellent PK/PD. For example, it is absorbed with the help of amino acid transporter in the intestine. It's got a short Tmax, a high Cmax. It has got approximately 90% bioavailability. Food does not alter anything. It's got favorable PK/PD characteristics that helps to penetrate tissues and reach excellent concentrations in the tissues that we need. It, it has got very minimal drug-to-drug interaction, and though its excretion is in the urine and the feces, it's got very minimal role in the renal pathway in the excretion of unchanged drug. Less than 3% is excreted, so it really doesn't require to have any drug dose changes. However, it may not work in urinary tract infection. That's a different story, but it really does not require much drug dosage changes even in patients of hepatic or renal impairment is what it looks like. Beautifully so, there also seems to be a situation um, where the Mroc oral actually mirrors the Mroc IV, clearly indicating that the bioavailability and the kill characteristics will probably remain the same, even if it is oral and IV, making it a beautiful switch from the IV to the oral formulation that we so much require. Importantly, it has got an excellent penetration into the lung. In fact, the epithelial lining fluid has got 7 times the amount of the drug as compared to that of the plasma, and thus it may form a great tool in our armamentarium to combat difficult to treat MRSA infections. Well, whenever we talk about these kind of new drugs, we say, show me the data. Well, the data is so much. I mean, let me show you one of these phase 3 studies that have been published in the JAPI. This is a phase 3 study that actually looked at efficacy and safety of novel broad spectrum anti-MRSA agent lemonadifloxacin compared to linezolid, the workhorse drug that we've been using for a long period of time for acute bacterial skin and skin structure infections, which was an open label randomized study that was done. What was done was there were 500 odd Indian patients that was randomized to Mroc O, that is the oral formulation versus linezolid oral, and an Mroc injectable versus a linezolid injectable. and they used it in concurrent bacteremia patients with acute bacterial skin and skin structure infections and diabetic foot ulcers. And what did they find out among the overall group? Among the overall group, they did find out that Mroc was 91% affecting cure rate versus 87.8% linezolid. And specifically in diabetic foot ulcer patients, it had a great clinical response with 91.7% curing and 76.9% only linezolid curing. Now, what is also important for us to understand is that there are barely any side effects that we're looking at with respect to levonadifloxacin. There is no, the vomiting incidence is low, the nausea incidence is low, the pyrexia chills are low, asthenia is low, hemoglobin decreasing is low, blood glucose increasing is low. There are no changes that occurs with respect to sugar. Cough, these are things that we normally look at in quinolones. We're not seeing any of these things. And that's why, in my experience, I've probably treated a large number of patients with levonadifloxacin. I still am yet to see major side effects, and each of these side effects are so small that it completely outweighs, the benefits of levonadifloxacin outweighs the small amount of side effects that this may create. And this is even much more lesser as compared to the existing drugs that we have. More importantly, you must understand that hepatic impairment, you don't need any dosage adjustment with respect to mild, moderate, or the severe form of hepatic disease. Thus, this forms a great drug that we could use for transplant patients. In fact, there is no change of QTC interval also. The red line that you see is moxifloxacin and the blue line is levonadifloxacin. And we clearly have, it is proven that there is really no QTC changes that would occur when we talk about levonadifloxacin versus moxifloxacin. Well, there are certain potential indications that probably we could use it for. It would be community acquired pneumonia, it is ventilator associated pneumonia, catheter related bloodstream infections, and I think that's where it's going to hold a key. Bone and bone joint infections. I mean, we've got a couple of case reports that are coming in where we've started treating patients with osteomyelitis with very prolonged duration of levonadifloxacin, and that's probably because of its superior side effect profile as compared to linezolid, and we'll come to that in a short while. It is also could be used in sepsis of unknown origin and febrile neutropenia. Well, let's compare these. Now let's take some time on comparing these molecules. Let's compare levonadifloxacin to vancomycin and linezolid. Well, levonadifloxacin can be given IV as well as oral, similar to that of linezolid, whereas vancomycin can be given only IV. The bacterial killing is superior. Levonadifloxacin achieves huge bacterial killing as compared to vancomycin and linezolid. The MIC breakpoints, 90 breakpoints, seem to be very low as compared to any of the other drugs. The lung concentrations are superior. The gram-negative coverage, of course, is not very good, but it is better than linezolid and vancomycin, which has absolutely no gram-negative coverage. The percentage of MRSA coverage of all these are comparable. Levonadifloxacin is more than 99%. It covers visa, anaerobes, and its GI tolerability is superb. Apart from a minimal constipation, I haven't seen another side effect of levonadifloxacin as of now. It's got an extremely potent bactericidal biofilm action against MRSA. No kidney toxicity, easily taken by oral route without any kind of GI issues. It does not cause myelosuppression. This is something that occurs with patients with osteomyelitis, where there could be myelosuppression when we give linezolid for a prolonged period of time. There is no dosage adjustment for renal injury or for hepatic injury for that matter. And hence, I feel even short term and the long term, levonadifloxacin completely outplays vancomycin, linezolid, and the rest of the drugs when you look at it for the MRSA or the gram-positive cover. Well, does it work for me? It's been working for me, and this is data that comes out from my hospital again, which actually shows that among all the quinolones and the gram-positive covers that we know, the MIC 50, MIC 90 is much lower as compared to rest of the molecules, indicating that the susceptibility profiling of levonadifloxacin is much better than moxifloxacin, levofloxacin, vancomycin, linezolid, teicoplanin, or for that matter, cotrimoxazole. It does work for me, for certain is what I feel. And I'm certain it will work for each one of you because of the fact that it has got such unique features, which includes the unique mechanism of action of a dual action on DNA kinases and topoisomerase 4, the rapid bactericidal action. It is suitable for long-term use. There is no dosage adjustment required for renal or hepatic. It is easier to switch from IV to oral. It's got better tissue penetration. It eradicates biofilms. It has got a unique structure with no QT prolongation, liver enzyme elevation, or phototoxic potential. It's got a very unique broad spectrum of coverage, gram positive, including MRSA, respiratory gram negative, atypical, and anaerobic bacteria. Thank you very much for the patient hearing, and enjoy the conference. See you then. Bye bye. Very nice.